Hello, and welcome to our live webcast, Meniscal Tears, Current Trends in Non-Operative and Operative Management. Thank you for joining us. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenter and will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete this survey in order to receive credit for attending and providing feedback for the webinar. We are joined today by our speaker, Dr. Jeffrey Siegel, and at this time, I'd like to turn it over to our speaker, Dr. Siegel, for opening remarks.
Hi, good evening. My name is Dr. Jeffrey Siegel. I'm an orthopedic surgeon here at Morristown Medical Center with offices in Morristown and Parsippany, New Jersey. And I'd like to just take a moment to thank Dr. Wittig and the crew here at Atlantic Health for setting up this webinar series, which I think has been valuable to my colleagues and to myself and my peers. So tonight, the topic is meniscal tears and discussing current trends in both operative and non-operative management. And so we'll dive right in. Just a brief overview. We're going to review some anatomy. Many of you may have not seen the inside of a knee for quite some time. We're going to discuss the clinical evaluation of a patient complaining of knee pain with particular focus on appropriate timing for imaging. We'll review the classification of these type of injuries, and then, of course, discuss the treatment of meniscal pathology. So looking at these images, the menisci, obviously we have two, a medial and lateral meniscus in each knee. And the image on the left, you're looking at a bird's eye view, so to speak, of the tibia. The menisci are C-shaped structures. They each have a posterior horn you see here, extends into the body, and then the anterior horn. You'll notice that the medial meniscus is a little more C-shaped, and the lateral meniscus out here is almost more round and covers more of the articular surface with less bone exposed. The menisci are wedge-shaped on cross-section, so on MRI and imaging, you'll see, like you see on the image all the way over here on the right, the triangular pattern that you'll see in MRIs that we'll look for to assess the meniscus. On the superior surface, they are a little more concave than this picture demonstrates, and that's to match the contour of the femoral condyle. In addition to the three main parts of the meniscus that I talked about, the posterior horn, anterior horn, and the body, another important part of the meniscus structure is the root. And so they're pointed out here in these slides. There's a posterior root for both the medial and lateral meniscus, and an anterior horn of both. And these are anchor points where the meniscus attaches to bone. The rest of the meniscus throughout the periphery is actually free-floating and attaches just to the capsule. So the only anchor points, again, are those meniscal roots, and they've become of much more clinical significance we've learned in the past 10 years or so. Just to review the histology, the menisci are made up of fiber cartilage. It consists of interlacing collagen fibers, primarily type 1 collagen. The extracellular matrix of the menisci consists of proteoglycan molecules as well as glycoproteins. But by weight, the menisci are about 70% water. The orientation of these collagen fibers is very important, and it belies its structural purpose. Most of the fibers are circumferential in pattern. So if you look at a meniscus like this, the fibers largely are running in that same C-shaped pattern, and that's to serve a purpose to absorb stresses that are transmitted from the femur into the tibia. There are some fibers that run perpendicularly, and they're considered radial ties. Without these, it's believed that you'd be more likely to get a split in the circumferential fibers, leading to tears in the meniscus. and then there on the surface there's some more irregular superficial fibers on top. The vascularity of the meniscus is very important. The blood flow to the meniscus originates from the popliteal artery, then to the genicular artery, and then the branches of the genicular artery provide capillary inflow into the capsule, which permeates into the menisci. But as you'll see in this stain-dyed slide, the meniscus is here. It's this triangular piece, and the capillaries only penetrate about the outer 1/3. The inner 2/3 of the meniscus is essentially avascular, and this plays a significant part as far as how we treat meniscus. An avascular tissue will not heal, and therefore injuries in the avascular zone are treated differently than injuries in the vascular zone. The function of the meniscus, many of us recognize, is to absorb shock and to transmit load. The way it transmits load is primarily the forces. Looking at the top slide here, the axial forces when you're standing or walking are transmitted from the femur in a longitudinal or axial direction. But when they hit the meniscus, those circumferential fibers that we looked at in the microstructure or histology of the menisci are transmitted from anterior to posterior and diffused in what's called hoop stresses. And those hoop stresses then are distributed by those anchor points, or what we call the roots, from the meniscus into the tibia. And any disruption of either the fibers of the meniscus or those anchor points doesn't allow those stresses to be transmitted properly to the tibia and allows to be overloading of the tibia or the femur, and it makes you much more prone to developing arthritis. In addition to absorbing shock and transmitting load, it's been recognized that the menisci play a role in stability. And so if you look at this picture on the bottom here where the car tire is, this orange wedge underneath it's called a chock block, and you can imagine that this tire can't roll back so easily because of that wedge. And so looking at the picture on the bottom left, the menisci serve a similar role. Now, the primary stabilizers to anterior and posterior translation of the tibia and femur relationship to each other are the cruciate ligaments, both the ACL and the PCL. But it's been known that the menisci are secondary stabilizers, and it's been found in patients who have ACL tears and are ACL deficient. They're much more likely to go on to meniscal tears because of the additional stress on the menisci. A couple other functions of the menisci are lubrication. Like I mentioned earlier, the menisci are about 70% made of water by weight, and it's believed the compression of the menisci with weight bearing causes them to secrete fluid, which lubricate the joint. And it's also been shown that the menisci have mechanical receptors and most likely play a role in proprioception. So getting into the clinical aspects of meniscal injuries, orthopedic surgeons usually will take a very focused history. Obviously, past medical history plays a role, but they'll usually dive right in when a patient presents with knee pain. And the mnemonic, which most of us learned in medical school, chloride, is very helpful in remembering the important points we want to try to cover in our history. So someone who presents with knee pain and we're concerned about a meniscal tear, we're going to try to assess the character of that pain. Meniscal tears don't necessarily have one particular character. Patients can present with dull pain that's been low grade, or can be much more intense and sudden. Usually the location is pretty distinct, though. Meniscal tears usually will cause pain along the medial or lateral joint line, so where you sort of see this person grabbing their knee on the inside here or out here. Anterior knee pain is not typically consistent with meniscal pathology, much more typical of patellofemoral issues. Occasionally, some patients will have posterior knee pain or a sense of tightness if they have an effusion in the knee. A big part of the history to me is the acuity or lack thereof of their onset of pain. An acute injury, to me, will often lead me down one path of diagnoses or possible diagnoses, whereas if patients had more insidious onset, I'm thinking about different possibilities. Often patients will provide a history sort of in retrospect, and they'll say their knee started hurting, and they think it was because they went hiking over the weekend, or maybe they did some gardening, but they didn't actually have a real acute moment. And to me, that's still more of an insidious onset. So by acute injury, I mean someone who remembers what I call an ouch moment. They were doing something, they felt sudden pain in their knee, and from that moment forward, they've had pain. that is provides a different likelihood of diagnosis to me than someone with a more gradual or a sudden gradual onset of pain. Meniscal pathology may radiate a little bit, like I said, posteriorly or into the tibia a little bit, but it's not going to radiate down the leg or up into the thigh very far. And if they're experiencing a lot of radiating pain, I'm usually thinking about other diagnoses. Intensity of pain is very variable from patient to patient. In general, patients all experience pain of different levels. These insidious type of symptoms are often low grade and more of annoyance than sharp pain. But someone with an acute injury obviously may come in even limping with much more intense pain. And the duration or how long they've had symptoms usually is corresponding to the acuity of their injury again. So a direct injury, they're often presenting within a day or days, where someone who didn't have a direct injury is usually coming in weeks to months later. And then lastly, we want to understand if they've figured out things that may have either helped or exacerbated their pain or mitigated their pain. So typical meniscal symptoms may be exacerbated by squatting or twisting. Sometimes they feel uncomfortable with the position of driving. The mitigating factors might be anti-inflammatory, certainly modifying their activities, things of this sort. A clinical exam usually starts with observation of the patient. Ideally, I like to try to watch a patient walk into the exam room. If I don't have that opportunity, I'll try to watch them walk within the exam room. I want to see if they have a limp, see how they're favoring their leg, if they're favoring it at all. I will then usually have the patient lay down on an exam table and with both knees exposed, looking for bruising, looking for any signs of erythema or infection, any rashes, skin changes for something like psoriasis. And then an effusion is the first thing I'll try to detect. And although a large effusion you can see, a subtle effusion is more of a feel. And I'll do this by trying to blot the patella and try to milk the fluid, which usually sits in the suprapatellar pouch above the knee, and push it down towards the joint line. And sometimes you can feel fluid in the knee that way. I always check the extensor mechanism, so I usually have them do a straight leg raise, and that will tell me that their quad tendon and their patella tendon and the patella are all intact. Check range of motion, make sure they can flex fully, extend the knee fully. Some patients with meniscal pathology can have a locked knee where they can either flex or more commonly they can't extend the knee all the way, and that could raise concern or red flag that there may be a displaced meniscal tear. Palpating the joint, you want to see if they have any direct bony tenderness, and then looking at meniscal tears, you want to palpate along the joint line. So on the top picture, you're looking at the lateral joint line. This crease in the person's knee is their biceps, part of their hamstrings. And up here, which you can't really see in the picture, is their iliotibial band. And the best place to palpate the joint line is where this hand is, which is sort of between the iliotibial band and the biceps. And if you get in that region, that's going to be the posterior horn of the lateral meniscus. And that's where more pathology is likely to be. Sorry, I was using the wrong arrow here. So that's in this area. This is the biceps, and this is the ITB. On the medial side of the knee, similarly, the medial collateral ligament crosses the knee here. And so, again, you want to sort of be in the posterior portion to get more direct access to where the tears happen, and also so you're not pushing directly over the MCL. You always want to assess the ligaments on an examination of the knee. And again, a medial collateral ligament sprain can sometimes be confusing. The MCL is intimately associated with medial meniscus, and sometimes both injuries will occur simultaneously, but anatomically they're located in a very direct area and can be sometimes hard to separate out by palpation. And then lastly, a thorough examination of the hip is always part of a knee exam to me. I say typically 2 or 3 times a year, I'll have a patient come in complaining of only knee pain. They're convinced something's wrong with their knee, and it turns out that they actually have hip pathology, often hip osteoarthritis. So I always move their hip and make sure that the symptoms aren't emanating from their hip. There are a couple of provocative tests that can be performed to try to elicit symptoms of a meniscal tear. Most classically is McMurray sign. And this, you see on the picture on the left, the patient is lying supine. The examiner will hyperflex the knee and then initially externally rotate the leg and then extend the knee to try to elicit any symptoms from the lateral meniscus, and then repeat it with the knee hyperflexed, internally rotated, and then extending, trying to elicit either pain or a clunk for the medial meniscus. The sensitivity of this test is not perfect. It's about 80%. Specificity is lower in the 60 to 70% range, and obviously it's very much dependent upon the examiner. The other test that's not that's as often commonly used is called the Apley grind test, and this is the picture on the right side of your screen there. And this is where the examiner will compress the femur and tibia together, and then internally and externally rotate the tibia, trying to elicit symptoms of meniscal pain. So usually after a history and physical, most orthopedic surgeons will obtain x-rays, and almost always those include weight-bearing films. The standard series in most orthopedic surgeons' office will include a standing AP, as you see on the right side of that picture, a lateral, which is done supine, and then what's called a sunrise or merchant view, where the patient's knees flex and we can see the patellofemoral joint. The image on the left of that screen is called the Rosenberg view, and this can help pick up sometimes more subtle forms of arthritis. So it's a flex view, knees about flex somewhere between 30 and 45 degrees, and it shows us another part of the weight-bearing joint. It's surprising that sometimes you can have a person who has had supine films done, maybe at the hospital or in urgent care, and the knee looks really not that bad at all. And then on a weight-bearing view, you'll see much more advanced arthritis, and that can alter the treatment significantly. So the weight-bearing views are very important. X-rays, as you see here, can show sometimes things that can be surprising. So the image on the left is a patient who had acute injury. It looks like a normal picture. Often patients will say, "Doctor, you sure I need an X-ray? I'm sure I didn't break anything." But where that red arrow is pointing is a capsule avulsion fracture, and it's called a Siegel fracture, and it's pathognomonic of an ACL injury. And then the picture on the right is sometimes seen in patients who are relatively young, in their 40s or maybe 50s, who don't have any history of arthritis, and they're complaining for the first time of knee pain. And this is already a fairly advanced or moderate amount of osteoarthritis, where you see bone spurs here in the lateral compartment. You see the joint space here is narrowed. And so these are all signs of osteoarthritis, and again, would alter the management of this case. So next step is formulating a differential diagnosis. And so this is my branching off point. The first step in my thought process is distinguishing that acute injury from that insidious onset of pain. So when a patient has had an acute injury, the things I'm thinking about, in addition to a meniscal tear, I'm thinking about a ligament injury. Again, we talked about MCL sprain, medial meniscal tears and lateral meniscal tears are very common in ACL injuries. In fact, ACL injury is more likely to have an acute lateral meniscal tear, but a chronic ACL injury is more likely to lead to a medial meniscal tear. Patients might have a condylar injury or a loose body in their knee. Tendon ruptures are usually more distinct and usually cause a different set of symptoms, but again, they're always examining the quad and patella tendon. Patella instability sometimes can be tricky. Very often, patients provide a very distinct history of their patella popping out, but once in a while, a patient may have an episode where the patella subluxates or even dislocates and spontaneously reduces, and they're unaware what happened. When that happens, they'll usually get injury to the retinaculum, which again is close to the menisci and may be confused if don't have that in your thought process. Certainly, a direct blow to the knee can cause a bony contusion, and certainly fractures. Fractures can sometimes be subtle with a patient who's had an impaction fracture or a hyperextension injury, or even in older people with osteoporosis, they may even have a tibial plateau fracture that from a low-grade injury that can lead to confusion between meniscal pathology. For patients with insidious onset of pain, no acute injury, the differential is a little different. So high on my list would often be osteoarthritis. There is increasing evidence that insufficiency fractures can occur from early osteoarthritis, but can occur spontaneously. It's called SPONK, or spontaneous osteonecrosis of the knee. And in these patients, we'll see normal imaging, but they may have an abnormal MRI where there's bone marrow edema in the femur or tibia. Patients who sometimes can have new onset of diagnoses of inflammatory arthropathy, such as rheumatoid or psoriatic arthritis, gout, and issues like this can cause usually swelling and pain in the knee. Usually a septic knee and infectious knee is usually very distinct, but Lyme disease is endemic in this area, and so a patient with an effusion, I'm always thinking about a possibility of Lyme. And then again, just to mention the referred pain, either from a spine problem, radicular pain, or hip pathology mimicking knee pain. So then the question often comes up if I may be thinking myself, but often the patient may say, do I need an MRI? And again, the determination for an MRI and how quick a patient will get an MRI is often related to the history. So a patient who's had an acute injury, I'm much more concerned, obviously, about structural damage, and that patient's more likely to get an MRI sooner, maybe even after the first visit. But a patient with insidious onset of pain usually doesn't need an MRI right out of the gate. And just to drive that point home, we'll look at some of the literature to explain why. So this first article is from Journal of Bone and Joint Surgery, JBJS. It was published in 2003, and it was evaluating whether there's value of working up patients who have osteoarthritis on X-ray, whether there's a role of getting MRI to assess for meniscal tears. And what they found in this study was that asymptomatic patients who have arthritis in their knee, 76% of them will have meniscal tears. So they're very common in patients who have osteoarthritis who don't even have any symptoms. Now, patients who had arthritis and had symptoms in their knee, 91% had meniscal tears. But interestingly, their pain scores didn't vary between patients who had meniscal tears and didn't have meniscal tears. So it seems to be much more of a function of their arthritis that's causing their pain than the meniscal tears themselves. The conclusion of this article was that the data does not support routine use of MRI for evaluating patients for possible meniscal tears if they already have osteoarthritis. There are some caveats to that, and that's particularly if they have mechanical type symptoms where their knee's locking and they're getting, buckling of the knee, and if their arthritis is more mild. But for the most part, if you're already seeing osteoarthritis, a meniscal tear is not the priority. Another study looking at the general prevalence of meniscal tears was done in New England Journal of Medicine in 2008. This was a Framingham study, different than the Framingham study most of you are probably familiar with. And what they did in this study was they randomly selected nearly 1,000 patients from a database, and they sent them for an MRI of the right knee. So some of the patients had symptoms in their right knee, coincidentally, and many did not. And what their data panned out was that nearly 20% of women in their 50s had meniscal tears. Men between 70 and 90, over half of them had meniscal tears. When they drilled down further on the data and they looked at patients who already had osteoarthritis on their X-ray, it's similar to that prior study. About 60% or so had meniscal tears, even if they had symptoms and even if they didn't. If they already had osteoarthritis, more than half would have a meniscal tear found. And interesting, the majority of the meniscal tears found in this study were 61%, in fact, were found in patients who had no prior symptoms in the past month prior to the study. So again, very high prevalence of meniscal tears in patients over 50 who don't even have symptoms, and even a higher percentage if they already have osteoarthritis. And then just one last study, because patients will often say, well, even if I have a meniscal tear and I have arthritis, can't you go in and clean up the arthritis doc? And there's not much of a role for arthroscopy to treat osteoarthritis. This study made a big splash when it came out. This was in New England Journal of Medicine. I think it was about 2001, and it may have been 2002. And what they did was, it was pretty interesting. They did a sham study, and they actually brought people to the operating room. Half of the patients had the actual operation where they had an arthroscopy. They were put under general anesthesia. Incisions were made, and the knee was washed out. No meniscal pathology was addressed. But the other half of the patients had a sham procedure where they were brought to the operating room. They were placed under anesthesia, and incisions were made, but nothing else was done. And so the patient and the examiner afterwards didn't know which patient had a sham procedure and which one had the real procedure. And they found really no difference between arthroscopic lavage and debridement for osteoarthritis than a patient who had placebo treatment. So this drives home the point that an arthroscopy can be very helpful for meniscal tears, but they do not help for patients with osteoarthritis. And since many patients who have osteoarthritis have meniscal tears, but their pain isn't any different if they have a meniscal tear or not, we don't really believe that treating the meniscal tear is pertinent, and we can't treat the arthritis for a scope. So the take-home message here is if a patient has osteoarthritis, and I mean by that a moderate amount or more, they're likely not a reasonable candidate for arthroscopy. So to get to the next question, so do I need an MRI? Let's answer that question. So there was a study published out of Europe. This is the European Society of Sports Medicine and Knee Arthroscopy 2016, and they came up with a consensus statement where a group of surgeons decided on what would be the best way to work these patients up. So this slide's a little busy, so I'm going to walk you through it. But once you see it, it's really not all that complicated. I did make a couple of modifications that are things that I follow a little bit differently. So they started with patients at age 35. I'm a little more liberal. I think 40 is a reasonable age, but you can use your own judgment for that. But patients roughly 40 years and older who have insidious onset of pain, so no acute trauma to the knee, and the knee is not locked. Those patients will have the history and physical we discussed, and then they'll obtain x-rays. And this is the first branching on point. If they have osteoarthritis on their x-rays that's moderate or severe, they fall into this osteoarthritis treatment bucket, and that patient is not likely going to ever have an arthroscopy that's going to provide any much benefit. And so there's going to be non-operative treatment and possibly at the end of the day a knee replacement, but there's not much we can do through arthroscopy. Presuming they have normal x-rays, they're 40-plus age, and they didn't have acute trauma, the initial step is going to be non-operative treatment, and we'll go into those details of what non-operative treatment includes in a moment. But many of these patients will have success. Their pain will go away. They'll go back to a normal active lifestyle. And obviously, if they have success, no further treatments needed, no further workups necessary. For the percentage of patients that fail and they continue to have pain, they come back and their symptoms are recurrent, that patient is now a good patient to consider an MRI for. So they get an MRI. If they continue to have pain now 2 to 3 months after the onset of their problem. And if they do have a meniscal tear, and they're not necessarily going to rush to surgery, so we want to look further at if there's other findings. So if that patient has some osteoarthritis that was not appreciated on x-ray, then we want to know really what is the meniscal tear or the arthritis causing their symptoms. And that can be very hard to delineate. That patient may benefit from additional conservative treatment, but what we often look for is they have mechanical symptoms. So if the patient has just general achiness and they're not getting catching and locking and their knee doesn't feel like it's giving way or buckling, they're going to fall into a treatment where the focus of treatment is more on the osteoarthritis, and they're going to go over here into this bucket where their focus of treatment is on osteoarthritis again. Doesn't mean they can't ever come back, but that patient, again, is not likely to benefit from an arthroscopy, and I'm going to really treat that patient for probably 6 months or 9 months before I consider even arthroscopy. For a patient who is having more mechanical symptoms, particularly if their arthritis may be in their medial compartment and their symptoms are more lateral, then that patient may benefit even if they have arthritis from an arthroscopic procedure. However, the ideal candidate is a patient here who has a meniscal tear on MRI. They have no symptoms of osteoarthritis, no radiographic evidence of osteoarthritis or other abnormalities, including bone marrow edema in the condyle or plateau. That person has an excellent chance of doing well from a partial meniscectomy, and that may be offered to them. So discussing the non-operative management now of meniscal tears. So the initial non-operative management includes things to reduce the patient's pain, so activity modification, avoiding things like squatting, pivoting, twisting can be helpful. If the patient started a new exercise program, modifying that exercise, often cycling usually would not elicit symptoms, and they can substitute their exercise with other activities like that. Ice is a good analgesic. It can reduce swelling and certainly can help with pain. It's been shown in several studies for people with degenerative meniscal tears that a long-term outcome from a non-operative program, including strengthening with physical therapy and a home exercise program, can be as successful as arthroscopic procedures for degenerative meniscal tears. And then judicious use of either oral anti-inflammatories or injections with cortisone can relieve pain. Now, obviously, none of these measures are going to really eliminate or fix a torn meniscus, and that's one of the things that often confuses patients is, if I have a 6-year-old and they already had an MRI, maybe by their primary, or maybe they were, I sent them for an MRI after they weren't getting better, and I saw more arthritis, they'll often be confused and say, well, if I have a torn meniscus, how is a cortisone shot going to help me? And it takes a fair amount of time to explain to them the literature. In general, the literature supports for men or women in their 60s, somewhere in the neighborhood of 45% of them will have meniscal tears just in the general population. And so we know that we don't need to operate on all those people. And so I explained to them that there's a 45% chance that their other knee, which may have no symptoms at all, has a meniscal tear. And they certainly don't want that knee operated on. And so the role of these treatments is to take a meniscal tear, which may be causing symptoms, but make it dormant and asymptomatic. And again, there's high success with these non-operative measures. Just to review MRI imaging before we get into some surgical management. So if the patient does have an MRI, we want to know what both a pathologic MRI as well as a normal MRI looks like. So this slide is of normal imaging of meniscal of the meniscal tissue. And so looking at the top left picture and the bottom left picture, this is our coronal views. So we're looking essentially at the equivalent of an anterior or posterior view of the knee. And on these views, you're seeing both the lateral meniscus and the medial meniscus on one slice. The meniscus can better be seen here. You see a black triangular piece that's low signal, and same thing over here, the medial meniscus, and that low signal solid black is what a meniscus should look like on the coronal view, and same thing on the sagittal view. So looking at the central picture, this is a sagittal view. The main distinction on the sagittal view is instead of seeing both the medial and lateral meniscus, we're seeing the anterior horn and the posterior horn. But again, it's triangular in shape both on the coronal view and on the sagittal view, and it should be low signal solid black triangle. Sometimes the meniscus can have some white inside it, and that is considered intrasubstance degeneration of the meniscus. But when we're looking for a tear, we're looking for that white signal to meet the border. If the white signal still has a solid black border around it, that's not something we would see during surgery, and it's unlikely to cause pain. Lastly, here is the axial view of the knee, and this is a little trickier because the meniscus is not commonly be seen on one particular slice. So on a couple of slices, you may see parts of the meniscus as these arrows point out. Looking at a couple of different types of meniscal tears on imaging. So these are both sagittal views of a knee, two different knees. This is the condyle, the femur, the tibia, looking at the anterior horn of the medial meniscus, and then the posterior horn here. If you look at that, you see this white line running right through the meniscus. So this is like a cleavage tear of the posterior horn of the medial meniscus, most likely a degenerative type tear. On this view, again, you're looking at the sagittal view. You got the anterior horn and the posterior horn, and right here there's a vertical longitudinal tear of the posterior horn of the medial meniscus, again, more typical in an acute injury. So in addition to classifying meniscal tears as acute or degenerative, which is a huge classification because, again, it dictates treatment largely, the morphology or the pattern of the tear can be helpful. The meniscal tear can be classified either as a vertical longitudinal tear, which is this tear in line of its fibers. So looking at this image here, if you remember that one of those first slides where the fibers of the meniscus, the collagen fibers run in this circumferential pattern, and the radial ties are supposed to hold that together, so that radial tie has failed and you get a split in this direction. And that is usually more of an acute injury type pattern. And same thing with the radial tear, which runs perpendicular to that and usually start at the free edge and propagate back towards the capsule. Horizontal tears better seen here is when the meniscus splits and like a fish mouth or bird's beak, and this is a typical degenerative tear. And then there are these flap tears and oblique tears that are more degenerative in nature. A couple of type of tears deserve special mention. This first one is called the bucket handle tear. And so this starts out as a vertical longitudinal tear like you see here. So again, a split in those circumferential fibers of the meniscus. And it may start out small and over time or from additional injuries may propagate. But once it gets to a size of this nature, what can happen is the inner piece here can flip on itself. So much like a bucket handle, if you think about the bucket here, this handle can swing back and forth. Well, this piece can swing like that bucket handle. And so looking at the image over here, this piece has now flipped. And obviously this can be a cause of pain, but it also can get stuck in this what's called the notch of the knee and cause the knee to lock. So this is more commonly associated with ACL injuries and acute injuries. On MRI, a bucket handle tear may look like this. So this is a coronal view of the knee, and you see the lateral meniscus out here, nice, solid, low signal, black meniscus. This is all normal. But when you look on the medial side, you see a truncated meniscus. You see just some of the black rim, but you don't see it coming to a nice point. But if you look in the notch here, you see something that looks abnormal, and that's the medial meniscal tissue. On the sagittal view, you may see something that looks like this. This is the actual PCL of the knee, this black band here. But in this knee, you actually see two of what looks like two PCL. So this is called the double PCL sign. And this the second dark image is actually the meniscus that's flipped into the notch. So this is, again, classic finding in a bucket handle tear. Arthroscopically, if you put the scope in the knee in someone who has a bucket handle tear, this is what you'll see. So to orient you here, this is the ACL of the knee. The camera is now in the medial compartment of the knee, and this is the condyle, the medial condyle. Down here where my arrow is pointing is the tibial plateau, and back here is the meniscus remnant, but most of the meniscus is here. It's been separated. This one is not flipped. If it was flipped, you'd actually see the mirror image with this part over here, but it's been either reduced or not flipped. But it either needs to be sutured back all the way back here, or if it can't be sutured, then it can be removed by amputating it here and in the front and removing this piece. The other type of the other type of meniscal injury that deserves special mention is called a root tear, and this is something that has only become evident in the past 10 to 15 years to bear significant clinical importance. So the root, we talked about, is the attachment site of the meniscus down to the bone, and it's been found that either from an acute injury, you might actually avulse that attachment off the bone, or you may get a degenerative type tear that creates a radial tear just adjacent to the root. And if it's within 1 centimeter of the root, it's been found that the entire meniscus is essentially rendered non-functional. And so someone who's had their entire meniscus removed has a much higher chance of getting osteoarthritis. So when it's been a root tear, essentially is the equivalent of a total meniscectomy, and that patient's at high risk for getting osteoarthritis. It's been found that this has a bimodal distribution. Again, the acute injury and occurring about 30% of patients, younger patients, usually associated with an ACL tear. And then the degenerative type tears around the root occurring about 70% of the root tears we're seeing. They're more common in middle-aged females with elevated BMIs. Looking at this MRI image, this is, again, a coronal image. You see the lateral meniscus out here. And if you follow the lateral meniscus across, it comes and connects right into the bone here. Looking at the medial meniscus now, it comes across. You get this increased signal where the red arrow is pointing, and then you see the insertion to the bone. So this is a root tear within about 1 centimeter of the root attachment. Arthroscopically, a root tear will look like this. So this is, again, to orient you, the tibia plateau. This is the femur, and we're between the two with the camera, and this is the meniscus coming around, and then it comes to a sort of an abrupt stop, and it should be connecting into this area where there's some hemorrhage. So this is, again, The meniscus is no longer connected to tibia and it's been rendered completely non-functional. What the data suggests is that about 80 to 90% of patients with a root tear will go on to rapid onset of arthritis within 5 years, with almost a third of them requiring a knee replacement. So this can be a devastating injury, or even without an actual injury, a devastating problem to have. And so patients with root tears, we've treated much more aggressively over the past 5 to 10 years, many getting root repairs where we can actually try to re-anchor the meniscus back into the bone. And if it's done before there's any significant amount of arthritis, you may be able to prevent that patient from going on to getting arthritis and maybe needing a knee replacement at a young age. So going on to the surgical treatment of meniscal tears, historically, meniscectomies were performed both open and as a total meniscectomy. So going back to the 50s and 60s, this was something a patient would get admitted to the hospital, often for a week even. They'd have a large open incision and the whole meniscus was removed, and they end up with arthritis certainly down the road within 10 to 20 years. So starting in the 70s and going into the 80s, the procedures have evolved to arthroscopic and trimming out only the abnormal, unstable meniscal tissue. Currently, this is one of the most common orthopedic procedures performed. There's been over 500,000 cases performed annually now for several years. A Lancet article in 2018 looked at the complication rate, and it was 0.37% rate of serious complications, and their serious complications included either PE or infection requiring additional surgery. Incidentally, though, and ironically, they found that the mortality rate and the MI rate was actually lower in the patients who had the procedure than the general population, and I presume this was due to selection bias and that patients who got cleared for surgery had less medical problems. The OR setup, just to show you, many of you probably haven't been in an operating room in many years, so the OR setup looks something like this, where the surgeon will either be facing the knee, and it can be done with either the knee flex hanging off the edge of the bed, or with the knee, with the patient supine and the leg straight out, and the surgeon standing next to the patient. On the opposite side of the bed in the background here, you see what's called the arthroscopic tower, and there's a monitor here, and most of the time the surgeon will have his or her eyes on the monitor looking at that, only really looking at the knee when introducing instruments into the knee. And then there's other equipment on the knee here called a light source, which provides, if you see this white cord here, that's actually was providing the light for the camera. There is usually an arthroscopic pump, which we fill the knee with fluid while we're doing the surgery, shavers and other equipment like this. The procedure nowadays is almost always a same-day procedure. It's usually done under general anesthesia, and the primary purpose or reason is that patients will almost always go home about a half hour to an hour after the surgery is done. And if they have a spinal or general, they'll have to be staying in recovery for several hours. The actual operation takes usually 20 minutes, maybe 30 minutes. And the goal is to resect the unstable meniscal tissue. We're not removing the entire meniscus. Analogy that I find patients can relate to is very equivalent to if you had a split fingernail or a hangnail, you would take a nail clipper, you wouldn't remove your whole nail, but you would trim back to the base of the tear and then smooth the transition back to the normal nail. And that's sort of what's done here. So this is basically a glorified nail clipper. It's a long, narrow instrument. It's called the basket, a meniscal biter or basket, and it allows us to, through a small incision, introduce it into the back of the knee, and then remove unstable tissue, and the meniscus should look something like this after the unstable tissue has been trimmed back. There are tears that are amenable to repair, and it's a big distinction, understanding that not all arthroscopic surgery for meniscal injuries are the same. So many of them, in the large majority, are treated with meniscectomy or partial meniscectomy, where we're trimming back the unstable tissue. But in an ideal circumstance, we're actually repairing the tissue. What dictates which procedure we do is largely based upon the tear pattern as well as the age of the patient. So looking at the bottom left picture, this is a vertical longitudinal tear in the outer 1/3, and that's that vascular zone we discussed at the beginning of the presentation. So a tear in this region will more likely have blood flow, and in a younger patient has a chance that it can heal. And so we can use devices like you see here. This is an all-inside device where we can pass sutures through the tear and cinch down the sutures and get the two pieces of tissue to be compressed together, and that may go on to heal. Tears, like you see here in the middle, is a radial tear. This has been repaired more commonly recently, and even though that's in the avascular zone, it may go on to heal. To pass these kind of sutures, we're using a device, something like this, where we can introduce the instrument that's long and narrow here into the knee, and by squeezing this trigger, it can actually pass the suture through the meniscus, and then we can tie that and try to get those two pieces compressed together. A meniscal repair has the advantage of restoring the function of the meniscus, which is huge and ideal, but all meniscal repairs aren't successful. So again, it depends on the vascularity and the age of the patient. The meniscal repair has a more prolonged recovery, often involving a period of non-weight bearing. Again, we want to protect and not put stress on that repair. One of the big downsides is that the literature suggests that even when it's done perfectly, only about 70 to 80% of meniscal repairs will actually go on to heal, and that means that 20 to 30% of patients may require additional surgery because the meniscal tear recurs, and now they need a second surgery to trim that piece out. So again, for an older patient who may be 50 or plus and they have a torn meniscus, even repairing the meniscus may not be advantageous because removing it, maybe they're at a higher risk of getting arthritis, but that patient may not want to be subjected to 2 surgeries and 2 recoveries. So I have a few cases that we'll go over, and then we'll go to some questions. So the first case is WK. He's a 50-year-old male who presented in my office. I think it was beginning of the summer, early summer, and he reported 2 weeks of right knee pain that developed after playing golf. He thought maybe he had a twist, but was mostly thinking about that in retrospect, didn't recall any particular ouch moment. He had pain immediately, which was aggravated with twisting or squatting. He wasn't having any buckling or locking. He was taking some ibuprofen, which gave him some relief, and his past medical history was only relevant for hypertension. On examination, he did have a small limp. He didn't have any effusion. He had full motion of his knee, but he definitely had discrete joint line tenderness along the posterior aspect of the medial joint line. He had a positive McMurray sign, and his ligaments were all stable. We did some x-rays in my office. Standing AP on the left here looked pretty normal. There was good joint space. Because of his age, I also did this Flex 45 PA Rosenberg view to look for any subtle arthritis, and it also looked pretty good. No bone spurs, good joint space preservation, and then the lateral and the Sunrise or Merchant view all look pretty normal. So a differential diagnosis at his initial visit included a medial meniscal tear, which I was concerned about. Speculated the possibility of a low-grade MCL sprain because he had this twisting injury, and of course was considering the possibility of some early osteoarthritis that I wasn't appreciating yet on X-ray. So he initiated conservative treatment. He was going to ice his knee. He was using a hinged knee brace and finding it giving him some relief, so he's going to continue with that. He was instructed in some home exercises, including quad set and straight leg raising. He was going to stop the ibuprofen, and he was going to try a short course of meloxicam for about a week, and then he was going to follow up with me in about 4 weeks. He did come back about a month later, and he reported that he had some transient improvement from the brace, but he didn't find the exercises or the anti-inflammatories were helping, and he was still having significant joint line pain. So at this point, I ordered an MRI. He came back a few weeks later, and this was what the MRI showed. So you see here a sagittal view and a coronal view. On the sagittal view, right where that red arrow appeared, is a disruption in the low signal of the medial meniscus. And that is what a tear looks like. And then it was also seen on the coronal view here where this red arrow is. And again, you see the nice solid black signal of the meniscus, and then the disruption, and then a continuation. So this is a radial tear of the medial meniscus, very consistent with the patient's symptoms. So when we reviewed his MRI, he was about 6 weeks from his initial presentation. We discussed pursuing further non-operative treatment to see if we can get this to become an asymptomatic tear versus considering arthroscopy. The patient was involved in playing golf for the summer. He didn't really want to have surgery in the summer and he had an upcoming trip, so we decided to pursue further non-operative treatment. He did come back, though, a month after that, and he was still having pain, and he decided to move ahead with an arthroscopy. So here's his arthroscopic pictures from surgery. The top left picture here is what I saw when I went into the medial compartment of his knee. So to orient you, this is his medial femoral condyle. This is the tibia plateau. And back here is the meniscus. And so if you follow the meniscus, this is that inner free edge of the meniscus. And then you see there's a double layer here. And this is what a tear will look like. I introduced my probe. This is the probe here, the silver line. And you can see how when I lift up that piece, it's like a big flap. And you can imagine that would cause pain much like a hangnail bending backwards. So to treat this, we can't just remove this section, and this was all in that avascular zone, not amenable to stitching back. So what we do is we start trimming it from the back, and we remove the tissue starting here, and what we call saucerize, where we trim the tissue out and then come back and narrow out as we come to the front. So the top picture on the top right here is after his meniscus was trimmed out. So now there's no unstable tissue. And this is a picture of his knee flexed a little bit, and he did have a little bit of arthritis. You see some fraying of the cartilage. This articular surface should be perfectly smooth, and that's what we call grade 1 changes and very mild osteoarthritis. The patient did return for his first follow-up visit. This was about a month ago. He was about 10 days out from surgery. He reported he felt great. He was not using any pain meds after surgery at all. He took maybe Tylenol the first night, and he felt like his preoperative symptoms were completely relieved. So hopefully he'll continue to have long-term success. My next case is DS. She's a 68-year-old female who came to me initially in February. She reported 1 week of knee pain that began after she just crossed her legs. She had a dull pain medially, which was worse with walking, but no buckling or locking, no prior injuries to her knee. Her primary had started her on meloxicam, and finding that it was helping. Past medical history had hypertension, type 2 diabetes, and a BMI of 30. Her exam was notable for joint line tenderness in the area where she described her pain medially, but no effusion, full motion, ligaments were stable, negative McMurray sign. She had x-rays in my office, including a standing AP, looked pretty good, even at 68. The joint space of the left knee here was preserved. The lateral view looks pretty normal. This sunrise view, again, showed some patellofemoral changes with a little bit of bone spurring of the patellofemoral joint, but really nothing too bad. So first of all, the differential diagnosis included a meniscal tear, but at 68, I was concerned much more about early osteoarthritis, and also concerned about maybe an insufficiency fracture where we sometimes see this spontaneous onset of bone marrow edema in the medial femoral condyle or medial plateau. So she was on meloxicam already and finding it helpful, so she was going to continue it for another week or 10 days. She was going to ice her knee. She was going to try to cut back on the excessive walking and only do the walking she needed to do, but not do any additional exercise. And then she was going to follow up with me a month later. When she returned a month later, she found that the meloxicam did give her good relief once she was taking it, but within a few days of stopping it, her symptoms recurred. And I didn't think with her history of hypertension, I wanted to continue on meloxicam long term. We decided on trying a cortisone shot to see if, again, we can get her symptoms to settle down. And so we proceeded with that, and she was going to follow up with me in a month if she continued to be symptomatic. She did have good relief from the cortisone shot, and she actually didn't come back for 7 more months. And she said that the shot gave her good relief, but it only lasted about 4+ months. At this point, her exam remained unchanged, and now I felt an MRI was appropriate. The slides that are in her MRI are shown here. The sagittal images of her knee starting from left to right. This is the lateral compartment. You can recognize that both the lateral plateau is a little flatter, and looking here, the medial compartment has a more concave appearance of the plateau, but also you see the fibula. So this is showing a lateral meniscal tear. I'm not sure how well that projects, but the meniscus has a nice black border superiorly, but the undersurface has a white signal in it. So she has a lateral meniscal tear. but the medial side of the knee looked pretty good. She had maybe a little signal inside the meniscus, consistent with intrasubstance changes, but no real actual tear that meets radiographic criteria. And then on this view here, there were some degenerative changes in the patellofemoral joint, as we knew from her x-rays. So when she came in and reviewed her MRI, we discussed the fact that she had a lateral meniscal tear, but she had some arthritis in her patellofemoral joint, and most of her pain was medially. So I didn't think an arthroscopy would be of any benefit, as her symptoms didn't correspond to where the meniscal pathology was identified. And so she was going to try some formal physical therapy, and if she wasn't improving, I thought that she might be a candidate for either Synvisc or visco supplementation. And then the last case that I wanted to present is a 48-year-old teacher. She presented in June with 2 weeks of deep knee pain. She had started a walking exercise program to help lose weight, and she speculated that this walking was causing her pain. Her pain was mostly posteriorly. She wasn't having any buckling or locking. She had no problems with her knee previously, but she was fairly uncomfortable, and she was taking ibuprofen at a moderate dose, 400 milligrams, 2 to 3 times every day, and wasn't really finding it was helping very much. She did have an elevated BMI at 34, but otherwise her history was unremarkable. On examination, she did have a slightly asymmetric gait, but it was felt this was most likely from a pre-existing ankle injury. She didn't have any fluid in her knee. She had good motion. She had medial joint line tendinitis, but a negative McMurray sign. One of the questions in the audience was, what is the McMurray sign? So if you might have joined a little bit late, so McMurray sign is a test we do on the knee where we, usually having the patient lie supine, will flex the knee up and then internally or externally rotate and extend the knee to try to elicit pain either along the medial or lateral aspect of the knee. You might hear a clunk or the patient just describes pain. And that's one of these provocative tests that can be used to try to delineate meniscal pathology. So back to this case, the patient had a negative McMurray sign. So the differential diagnosis, I'm sorry, before we got to the differential, her x-rays looked pretty good. She had standing AP view, really despite her BMI, looked pretty normal. Patellofemoral joint looked good, lateral view all looked normal. So her differential diagnosis included a medial meniscal tear. I was concerned about stress overload with her walking program that she was doing a lot of. And again, with her BMI being elevated, I was concerned that there might be more osteoarthritis in the joint than I was appreciating on x-ray. So she was already on pretty good doses of NSAIDs and still not really feeling much better. So she was going to cut back on her walking program, maybe try cycling. And then we discussed a cortisone shot because she was uncomfortable, and we proceeded with an injection that day. She did pretty well from the injection for 2 months. She came back about 3 months later, and she reported that she felt well for a while, but now she was actually worse. She was limping. She was started back on the ibuprofen by her primary and also added gabapentin. At this point, I felt an MRI was appropriate. And the patient came back shortly thereafter with the MRI, and these are the images of her picture. So looking from left to right here, this is a coronal view of the knee. The medial meniscus is here. You see the fibula here, again, to cue you in on medial to lateral. And nice, solid black signal. Didn't look bad, but if you follow this coronal image across, you get that white signal right here, and then you see the stump of the meniscus. So this is a root tear. The right where that red arrow points. The second thing, if you look at the middle picture, is the medial meniscus should be sitting flush with the medial plateau, and you can see the meniscus protrudes medial to the plateau. And so this meniscus is called extruded, and this is another finding we see in root tears. And then lastly is on this last image, the saddle image, you see that the meniscus is barely evident in the back, and that's called the ghost sign, where you just see the gray shadow of where the meniscus should be. So this patient was 48. She didn't really have much arthritis on x-ray, maybe a little bit on the MRI. And we know from the literature that patients with mid-root tears will have a very high incidence of going on to developing osteoarthritis pretty rapidly, and many of them needing a knee replacement. So she was indicated to undergo a meniscal root repair. So I have a small video I'm going to play due to the technical problems we've had here. So we had to have the video clip separately, so I'm going to play that in a minute. But just to set up the video here, the video is going to start with some part of the procedure performed already. So initially, the first thing we do is we're going to want to get a stitch in the meniscus stump. So looking at the top image on your screen, this is an instrument that can go in through the knee, and it helps us pass a stitch like you see here through the meniscus, so we get control of the meniscus. And the objective in a meniscal root repair is to pull the meniscus back down to the bone and anchor there. So the way we do that is we drill a hole in the bone. If you look carefully right by my green arrow here, there's a black circle. That's where there's a hole drilled, and that comes out the front of the tibia. So looking at the bottom image, the way we drill that hole and get that there is there's a device, this is called the drill guide, and this arm goes in through the small incision in the knee, and we can position this arthroscopically where we want the root to be attached to, and we put that at the native root attachment site. And then the rest of this device is all outside the knee, and through a separate small incision on the front of the shin here, we can put this drill sleeve, and then we drill a drill bit or a wire that goes from the front of the tibia up through the tibia and makes a hole right at the root attachment site. And then the objective is to pass the sutures that are through the meniscus here back down through that tunnel and then tie them on the front of the tibia. So Megan, if you can play that video, that would be perfect. So what you're looking at on this video, you see the sutures. I'm not able to point here, but there's green sutures in the meniscus. You see me tugging on the meniscus there, and then you see a black cable coming up. That cable's through the hole that I drilled at the root attachment site. And I'm grasping that black cable, which is really a loop, which is going to allow me to shuttle the sutures that are in the meniscus through the tunnel. So I'm grabbing that black loop, and outside the knee joint now, I'm putting the green sutures into the black cable. And now when I pull on the black cable, which the other end is in front of the knee, you can see I can shuttle the sutures down the tunnel. And now I have the sutures outside the front of the knee. And when I pull on those sutures, you can see I can reduce the meniscus and pull it back to where it belongs. So I'm tensioning it. I'm checking that the sutures have a good bite in the meniscus, pulling it back down. And then I'm going to use some device. There's a few different ways, but in this case, I was using an anchor. So I'm loading those sutures on an anchor. I'm going to retension the sutures and make sure I like where the meniscus root is sitting, make sure it's compressed down to the bone. And then I'm going to seat the suture. So there I'm tensioning it again, making sure I like where it is, and now I'm seating that anchor. And then I'll check it and make sure, and I'll put a probe in, and so you see my probe coming in here. And I'm going to probe the meniscus. Now you see I can't lift up that end, and it's anchored right down to the bone. So hopefully this will allow that patient's meniscus to heal back down to the bone, restore the normal distribution of forces across the knee, and maybe prevent this 48-year-old from going on to arthritis and needing a knee replacement at a young age. So at this point, we'll go on to take some questions. I'm going to see if I can open up the screen a little bit here and see the questions that people have asked. So the first question was, does age impact ordering an MRI? And it certainly does play a role. The age, again, most of the studies show as we get above 50 that we're much more likely to find a meniscal tear just from degenerative changes in the knee. And so I've been accused of discriminating patients based upon their age in a fashion that, that sometimes gets them angry. But many patients who have meniscal tear, if they're over 50, may do well with non-operative treatment. So again, I'm going to encourage that patient to pursue non-operative treatment first, unless I'm really concerned about some serious structural damage or a fracture. I'm going to try usually non-operative treatment initially. But if they had an acute injury, certainly there are 50-year-olds who are still very active and may play sports. And if I'm concerned that they either have a locked knee, acute injury to their ACL, they may get an MRI much quicker. But if they have insidious onset of pain, I'm much more inclined to treat them non-operatively first before getting an MRI. And certainly, more importantly, though, is the question is, do they have osteoarthritis? If they have osteoarthritis, I explained to them that there's not any diagnostic dilemma. The MRI is helpful when we're not certain of the diagnosis, but once we see osteoarthritis on plain X-ray, even if it's moderate and certainly if it's advanced, the MRI doesn't have much of a role. The next question I have is asking, the rest of the questions cut off. It says, I have found many patients have significantly worse arthritis seen, I presume, on the MRI, and that certainly can happen. Sometimes from a plain X-ray, you may not appreciate much arthritis. Again, if you looked at some of those slides, a standing X-ray, you're primarily seeing one part of the condyle against the tibia, and a flex view of the knee may show us more subtle findings of osteoarthritis. The next question I have was, after a meniscal repair, can a tear recur? And certainly, so sorry to see if I can get these rest of these questions to open up. So if we are successful in repairing the tissue, then the good news is that the meniscus is restored and the function is restored, but it doesn't mean it's impervious to further injury. In contrast, someone who's had a meniscectomy, in theory, they can have a new tear, but it's much less likely because a portion of the meniscus has been resected, so there's less tissue to tear. And the second thing that gets tricky is that after someone's had surgery on the meniscus, and if it's been resected, the meniscus doesn't look normal. And so often a second MRI, even years down the road, the radiologist will read the MRI as showing possible new tear versus postoperative changes. And it can get tricky to identify a new tear in someone who's had a prior meniscectomy. The next question is, what percentage of meniscal tears get larger if untreated, and which tear types are more likely to progress if treated conservatively? So this is a good question, and this is something that comes up a lot by patients. They say, my knee is feeling better, doc, but I have this tear. Don't we need to do something to prevent it from getting worse? And the reality is that we don't treat meniscal tears to prevent them from getting worse. We treat them for the symptoms. So again, many people will have meniscal tears. Once the meniscus is torn, that tissue is not functional. So the other question that patients often ask is, well, if we trim out the meniscus, am I more likely to get arthritis? And the answer is, once you tore the meniscus, you're more likely to get arthritis. So the meniscus tissue that's torn is non-functional, and from the moment the patient has a meniscal tear, that increases the risk of getting arthritis. And removing the meniscus or performing a meniscectomy is strictly to alleviate the pain that it's causing, but it doesn't restore the function of the meniscus. So the arthroscopic partial meniscectomy doesn't diminish the risk of getting arthritis, but it doesn't increase it either any more than it did from them having the tear. So if a patient has a meniscal tear, and if it got larger, if it remained asymptomatic, it wouldn't change our management. So we don't really know the answer of how many of these tears will become larger, but we don't necessarily get concerned if they're larger as long as they're asymptomatic. And so we don't ever really go in and operate on someone who has an asymptomatic tear just to prevent it from getting larger. And so the treatment is based upon symptoms. Next question was, when we do a meniscal repair, how do you follow up to know that it worked? It is primarily clinical in the sense that it's interesting that a lot of these patients have have a hard time describing their pain, but after surgery, they can often clearly tell you their pain is gone. Often they have a deep ache. It's not typical meniscal pain where they're getting sharp, sudden pains, but they'll often know that their pain is gone. It's usually clinical follow-up. Of course, if you're concerned, you can get a new MRI to see if the root has healed, and certainly in research studies, they do perform these MRIs routinely. But in clinical practice, we follow patients clinically. And it takes about 3 months for that root to really heal and the meniscus to reattach to the root. So the recovery from a root repair is much more in line with an ACL reconstruction than a typical meniscectomy. And sometimes patients are confused because they say, well, my friend of mine had a knee arthroscopy for a meniscal tear, and they're walking a week later. Why do I need to be on crutches for a month? And so a meniscal repair, particularly a root repair, is going to have a more prolonged recovery, hopefully with restoring function of the meniscus, but it is a longer recovery, and so not all arthroscopic knee surgeries are the same. And the last question I have in the field is, one of the last questions is, do you need an MRI or an arthrogram after prior surgery? So an arthrogram definitely can help delineate post-operative changes sometimes. So again, if a patient goes for an MRI after surgery, again, many years later, if they're having pain again, initially I'll send them for just a plain MRI because it's non-invasive, there's no radiation, and see what it shows. But I'll warn them in advance that if the findings are uncertain, they may need to go back and get the arthrogram portion where their knee will be injected with contrast, and that can help delineate sometimes post-operative changes from a new tear, but it's not perfect. So again, someone who's had prior meniscectomy, I'm very slow to bring back to the operating room. If they've had a prior meniscal repair, certainly there's more likely to be a likelihood that that repair may have failed, particularly if they've had an ACL injury which wasn't fixed, or if their ACL got retorn, they're more likely to have a re-tear in the meniscus, and then I'd be more inclined to get an arthrogram.
All right, Dr. Siegel, I'm so sorry to interrupt, but it looks like we have run out of time.
Sure.
So we just wanted to thank you for your presentation, and on behalf of Atlantic Health Systems, Morristown Medical Center Orthopedic Surgery, we'd like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this survey in order to earn credit for attending the webinar. This will conclude today's program. Thank you again, and enjoy the rest of your evening.